Okay, Dr. Santosh. He's going to be presenting on innovative, what is that, OT? FGE, superior to OPD FGE, non-absorbing post-vitrectomy reblade. Okay, you get it.
So respected chairman, co-chairman, moderator and judges, very good morning to one and all. I am going to present a video with voice on. Please play the video. It's a very innovative technique of OT, fluid gas exchange or fluid air exchange we can call.
Technique of OPD FGE that I call as OT FGE. Now in this video, using a 26 gauge bent needle through the sclerotomy site in the horizontal meridian, and I am using fluid air exchange. FG port is used to inoculate the air with pressure inside the vitreous cavity, which is on the nasal side. You can see the 26 gauge needle, and on the temporal side the needle is open, and 30 to 40 pressure is set for fluid air exchange. And now you can see the blood is drained from the temporal side. So pressure is well maintained. Patient is in lying down position. You can utilize microscope light and the magnification, and moreover the advantage at the end, you can inject anti-VEGF intravitreally. See, the magnification and light very well used, and patient is little bit turned on the temporal side so that the drainage will be more. Now this is the fluid air exchange tube which is attached to the FG port on the console. So thank you very much for your patient listening. This is the modified OPD FG that I call as OT FG. The advantage is that it can be done in lying down position as against OPD FG which is done in sitting posture. It is cumbersome for the patient as well as doctor, and you have to perform with the help of indirect ophthalmoscope, and IOP is fluctuating. You cannot monitor it, and also you cannot inject anti-VEGF injection in OPD FG cases. So it has a good modification in a vitrectomized recurrent hemorrhage, vitreous hemorrhage cases in diabetic, proliferative diabetic retinopathy cases. Thank you very much for your patient listening.
Thank you, sir.
Any retina person here? Yes.
You are making two ports.
Yeah.
So you can make extra one port and you can do a complete fluid air exchange, because if you're going to give a half an inch needle inside, so it will not completely drain. So the posterior, part of the vitreous cavity will still be having the blood. That will not be cleared, right? So it will not do a complete evacuation of blood from the vitreous cavity, this procedure.
No, just it is a vitrectomized eye.
Right.
So
yeah.
there is a pressure inside the vitreous cavity that will automatically drain the fluid from blood from the vitreous cavity.
No, only till
because of the pressure only.
Yeah, only till the tip of the needle. But what about the blood which is collected below the level of the needle? Because it will not be
because
over
of the pressure it will be drained.
No, over the disc it will
and
not be.
The aim is around 80 to 90% we want the drainage. 10 to 20% even if it remains, it won't create any problem, because it will get absorbed with the time.
No, instead of that you can put a third port and evacuate 100% of the blood.
But we have to then attach everything. We need all the vitreous instrument then. So it's a big procedure.
No,
just as against OPD FG, we are modified our technique.
No, when
in a sterile environment we are doing in OT.
Right.
Yeah, and also we can inject the anti-VEGF. That is very much required in such cases.
Any more chances of infections here? Because I think you are doing it with the 26 gauge needle, 30 gauge needle.
Yeah, 26, 30 gauge.
So don't you think there will be more chances of infections?
Infection?
Yeah.
No. We are doing in a sterile, we are in OT only we are doing this all this technique, and it is in sterile environment. As against OPD FG, that is done in OPD. So that is more, I think, infection probe.